Evaluating a patient with a declining neurological baseline is one of the most complex tasks on the ward and on Step 2 CK. The diagnostic challenge comes down to mapping two overlapping variables, the tempo of the decline and the presence of highly specific localizing signs. We can untangle this by building a master triage algorithm. Every patient presentation starts at this central node: generalized neurological decline and CNS symptoms. The first critical split is the tempo of decline. We have to separate the chronic progressive dementias from rapid deterioration and isolate presentations that follow a distinct stepwise drop. On the other side, we branch into secondary causes. This path isolates prominent motor findings like ataxia and systemic factors like a history of HIV or adrenal insufficiency. Downward, we build the structural branch. This path captures the triad of mass effect: dull, poorly localized headaches, raised intracranial pressure, and new onset seizures. Finally, we add a branch for superficial findings, specific skin and eye markers that point directly to complex neurocutaneous genetic syndromes. This top-down clinical pattern recognition provides the structure required to navigate complex clinical vignettes under test day conditions. We begin with the tempo branch, specifically differentiating chronic and stepwise cognitive decline. This table compares two tested pathologies. Left, frontotemporal dementia. The early feature is insidious behavioral change, apathy, disinhibition, and hyperorality. Contrast with vascular dementia. These patients experience early executive dysfunction. The timeline is a stepwise decline following acute ischemic events. Neuroimaging confirms. FTD shows severe frontal and temporal atrophy. Vascular dementia presents with multifocal deep white matter infarcts. Medical management for vascular dementia centers on strict, aggressive treatment of cardiovascular risk factors like hypertension and diabetes to prevent further small vessel ischemia. If the tempo of decline is measured in weeks or months rather than years, the algorithm shifts to the rapid tempo branch. The classic presentation here is Creutzfeldt-Jakob disease. The classic metastasis profile shows multiple, well-circumscribed lesions at the gray-white junction, surrounded by expansive vasogenic edema, exerting heavy pressure on healthy tissue. This rapid cognitive decline is accompanied by a wide array of focal deficits, including pyramidal hyperreflexia, extrapyramidal hypokinesia, and cerebellar ataxia. This graph illustrates the required EEG diagnostic criteria for CJD: periodic, sharp, triphasic, and synchronous electrical discharges. Cerebrospinal fluid analysis will show positive 14-33 protein titers and a positive RT quick test. A brain biopsy, the definitive gold standard, reveals widespread spongiform degeneration without active inflammation. Differentiating these dementias requires matching the exact tempo of decline, gradual, stepwise, or rapid, with the primary early deficit, whether that is behavior, memory, or motor control. Moving to the ataxia and systemic risk branches, consider a clinical triage vignette. A young male patient presents with progressive cognitive impairment, severe ataxia, and noticeable skin hyperpigmentation. This specific triad maps directly to adrenoleukodystrophy. ALD is driven by an X-linked mutation in the ATP binding cassette transporter, leading to long-chain fatty acid accumulation that damages both the nervous system and the adrenal glands. The hyperpigmentation is a direct result of primary adrenal insufficiency. As cortisol levels drop, the anterior pituitary overproduces ACTH and melanocyte-stimulating hormone, darkening the skin. Social history defines the next branch. A history of heavy alcohol use over a decade points towards alcoholic cerebellar degeneration, which specifically targets the Purkinje cells in the cerebellar vermis. Because the vermis controls truncal coordination, this degeneration presents a severe, wide-based gait ataxia. Notably, unlike primary dementias, the patient's general cognition remains relatively preserved. Another major systemic trigger is HIV neurocognitive disorder, which typically emerges in patients with long-standing infections and CD4 counts below 200. It presents as a clinical triad: impaired memory, distinct personality changes, and physical motor slowing. A brain MRI will correlate these symptoms with diffuse brain atrophy and increased white matter intensity. When cognitive decline pairs with distinct systemic markers like hyperpigmentation or severe immunosuppression, the primary dementias are off the table. The diagnostic tree must immediately target these secondary systemic syndromes. Next, we execute the structural mass effect branch. A CNS tumor often remains clinically silent until it compresses surrounding tissue. The red flag presentation is a dull headache that worsens at night, accompanied by nausea, vomiting, and a new onset seizure. The immediate next step in management for this cluster of symptoms is an MRI of the brain, both with and without contrast. This cross-section highlights two high-yield locations. Stellar masses in the anterior region will compress the optic chiasm, causing bitemporal hemianopsia alongside profound endocrine dysfunction. Posteriorly, pineal masses cause Perinaut syndrome, an inability to look upward, and often trigger obstructive hydrocephalus by blocking the cerebral aqueduct. Statistically, the most common brain mass is not a primary tumor, but a metastatic lesion, frequently originating from a primary lung cancer. The classic metastasis profile shows multiple, well-circumscribed lesions at the gray-white junction, surrounded by expansive vasogenic edema exerting heavy pressure on healthy tissue. Surgical resection is generally indicated only if there is a single, surgically accessible metastatic lesion in a patient with a strong overall performance status. Let's run our rapid diagnostic check. An MRI reveals a solitary extraaxial mass with a thick projection extending along the dura, often described as a dural tail. This points directly to a meningioma, a typically benign, slow-growing tumor presenting on the brain's surface. Vestibular schwannomas present entirely differently. Located at the cerebellopontine angle, they cause unilateral sensory neural hearing loss, tinnitus, and severe imbalance, requiring a dedicated internal auditory canal MRI for diagnosis. In infants, a choroid plexus papilloma creates structural pressure not through a massive solid tumor, but through localized massive overproduction of cerebrospinal fluid. Cranial masses must be clearly differentiated from spinal cord compression. Spinal lesions present with distinct sensory levels, ascending motor weakness, and autonomic bowel and bladder dysfunction. Localizing a structural lesion requires pairing the generalized signs of raised intracranial pressure with one single defining focal deficit. That combination dictates whether the primary pathology is cranial, metastatic, or spinal. The final branch of the algorithm maps superficial dermatologic and ocular anomalies to complex genetic syndromes. This comparison chart maps the neurofibromatoses. Type 1 presents with café au lait spots, Lisch nodules, and optic gliomas. Type 2 is defined by the pathognomonic presence of bilateral vestibular schwannomas and early-onset cataracts. Tuberous sclerosis has a widespread multi-organ impact. Superficial ash leaf spots and childhood seizures link directly to severe internal findings, like cardiac rhabdomyomas and renal angiomyolipomas. Von Hippel-Lindau disease connects retinal and cerebellar hemangioblastomas to a high risk of developing clear cell renal cell carcinoma. Finally, Sturge-Weber syndrome is characterized by a prominent port wine stain localized to the V1 ophthalmic distribution, ipsilateral leptomeningeal vascular malformations, and early-onset glaucoma. On test day, these superficial dermatologic findings serve as immediate clinical predictors for severe hidden systemic and oncologic pathologies. Now let's run a rapid-fire review of the most critical diagnostic associations to fully lock in the algorithm. Insidious behavioral onset combined with hyperorality indicates frontotemporal dementia. Stepwise cognitive decline matching cerebral infarcts points to vascular dementia. Rapid fatal dementia presenting with startle myoclonus is Creutzfeldt-Jakob disease. A young male with ataxia and adrenal insufficiency requires a diagnosis of adrenoleukodystrophy. Multiple gray-white junction lesions surrounded by vasogenic edema confirm metastatic disease. A V1 port wine stain paired with seizures identifies Sturge-Weber syndrome. Step 2 CK neurology is a rigorous test of pattern recognition. Execute this decision tree strictly, match the tempo to the deficit, and you will consistently land on the correct diagnosis.